Hello, everyone, and thank you for joining the webinar, Innovative Use of Technology in Primary Care Delivery. Before we begin, we'd like to go over a few housekeeping details before we begin today's content. First, please note that today's webinar will be recorded. To ensure audio quality for all attendees, we've muted everyone's lines. This will enable you to hear us, but we will not be able to hear you during the webinar. We encourage you to ask questions through the chat feature located on the lower right-hand side of your screen. We will hold a Q&A discussion after all of the presentations have finished. Finally, automated closed captioning is available to all attendees. To enable or disable the captions, please click the CC button located on the lower left-hand side of your WebEx window. I'll now pass it to Matt Simpson to introduce today's content.
Great, thank you very much, and welcome everybody to our webinar here today. This is the third in our series, and it's going to be on the innovative use of technology in primary care delivery. But on the next slide, just want to give a quick disclaimer that the views in this webinar do not represent official views of the U.S. Department of Health and Human Services or the Agency for Healthcare Research and Quality, and is rather a highlight on some of the research findings and methodologies used by grantees of our agency. On the next slide, I'll just take a quick moment to introduce myself. My name is Matt Simpson, and I'm a family physician within the Division of Practice Improvement in the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality. We'll often refer to ourselves as AHRQ, or AHRQ for short. I work very closely alongside one of my colleagues, Amy Eden, who's the current acting director for the National Center for Excellence in Primary Care Research. On the next slide, you can see text from AHRQ's 1999 authorization that demonstrates the role that was envisioned that a Center for Primary Care Research should have within the government. With this, we've operationalized that into several working areas that you can see on the next slide. And with that, you can see that for point number 4, really talking about trying to build a more robust and systematic dissemination strategy. The webinar series that we're hosting here today is part of that effort to really highlight some of the research that AHRQ is interested in commissioning related to primary care, and work that we're really interested in within NICE PCR, which is how we often refer to our National Center for Excellence in Primary Care Research. On the next slide, you can see that the focus for today is going to be the innovative use of technology in primary care delivery. This is the third webinar in a series that we're hosting. If you're interested in the previous 2, recordings are available on the NICE PCR website. So this one will be recorded, as was mentioned, and will be posted there as well. We mentioned this is a series of webinars, so please stay tuned for upcoming webinars and stay up to date through various AHRQ channels and listservs for that. All right, on the next slide, we can see the objectives that we have for today's webinar. And we'll really get to see how some of the research that we've funded uses technology such as text messaging, machine learning, or mobile apps to really advance AHRQ's mission to make healthcare safer, higher quality, more accessible, equitable, and affordable. And I'm really excited to highlight some of these projects because I think that it demonstrates how technology can really be incorporated into primary care and primary care research in very meaningful ways. To help guide us through the webinar, I've got one of my colleagues who will be moderating. On the next slide, you can see him in his wonderful suit. This is Dr. Ed Lomaton. He is a senior advisor for clinical informatics in the same center as I'm in, the Center for Evidence and Practice Improvement at AHRQ. He is going to facilitate the question and answer session that's going to come at the end of all the presentations. Thanks for being the moderator today, Ed. I'm going to pass it over to you.
Thanks, Dr. Simpson. So we are delighted to have 4 primary care researchers here today. They will each discuss their research on the innovative use of technology in primary care delivery. Let me first introduce our first presenter, Dr. Anjana Sharma. from the Department of Family and Community Medicine, University of California, San Francisco. And Dr. Sharma will be presenting on her study, Experts PC, Engaging Patients in Event Reporting for Safety in Primary Care. So welcome, Dr. Sharma.
Hi, good afternoon, good morning for those on the West Coast, and thank you for the kind introduction. I'm so excited to share some of our findings from the AHRQ funded K08 project, which is called Engaging Patients in Event Reporting, where we're really seeking to use text messaging and online tools to help improve primary care safety. So on the next slide, I can share some background. So as a practicing primary care doc myself, I'm a family physician, and as many of you are likely agree, primary care and outpatient care is the most utilized form of healthcare, and yet primary care safety often doesn't get the attention it might deserve. And from what we do know, 5% at least of adult outpatients have experienced some sort of diagnostic error, and at least 4.5 million ambulatory care visits may be related to adverse drug events or medication safety problems. And so our team is really passionate about the fact that in primary care and outpatient care, patients, families, caregivers, they're the ones really driving care and driving care safety. They're the ones navigating between different providers. They're the ones self-administering often high-risk medications. So, we asked, why aren't patients more involved in the processes to make primary care more safe? And so that's what led us to this K08 proposal. Next slide, please. We were really interested in text messaging, and we really honed in on that because it is so popular, it's so utilized, and it seems like it can really be a tool for increasing access. And even if you look at the Pew Research, for example, even very low income individuals will still have a smartphone. And so we thought that there was really something there. And I wanted to highlight my mentor, Dr. Naomi Bardak, who's a pediatrician. And Dr. Bardak's work has looked at text messaging specifically for patient-directed safety reporting. And she has looked at it in the pediatric care setting, where inpatient pediatric patients and their families, their parents, their caregivers can real-time report when they have some sort of safety concern using text messaging. So we really were interested in that as a tool that had been shown to be really promising in the inpatient care setting, but what about for primary care and outpatient care? So we can go to the next slide, please. And so all of this work was really done very closely and in concert with a stakeholder advisory research council, and I really wanted to highlight that up front. And so everything we've done in this work is really in partnership with our stakeholder advisors. The structure is about half patients and family members and caregivers, and then half members of the primary care team. So that includes family docs, nursing, a doctor of pharmacy, medical assistants as well. And we really tried to have the majority be patients and caregivers, and the minority being within the group being healthcare professionals, to really address the power dynamics at play. And the groups met throughout the pandemic. We flipped to Zoom, then we sort of went back to hybrid, and I've often am asked, what do advisors actually do? In this project, they helped us inform all of our study procedures and protocols. They revised our recruitment materials. They piloted our recruitment protocols real time, and they have reviewed all of our collected data. They have weighed in on our interpretation and discussion, and then they're also formal co-authors in any of our publications of our academic manuscripts. And so just to give a little testament to the experience, I wanted to highlight a video that one of our patient advisors, Mr. Patrick McKenna, was able to record for this webinar today.
Hello, I am Patrick McKenna, a patient advisor at Zuckerberg San Francisco General Hospital, and also a participant in Dr. Sharma's Patient Safety Notification Project. In the past 17 years, I've been in and out of general hospitals, clinics, and the emergency room many times, way beyond several hundred times actually. Mistakes that negatively affect patients do happen, but patients are hesitant to report such issues. To have a means of reporting problems with patient safety in a secure manner is extremely important. This is what Dr. Sharma, Amber, and Hiba have done. I would love to see this project become a daily resource in many hospitals. Every opportunity that allows patients to communicate with doctors and administrators needs to be offered to patients. Personally, I have complicated medical issues. Difficult problems do arise during my care, and it's not easy to communicate them. This project allows me to communicate what I find difficult to state. Thank you.
Thank you, Patrick. So that's the how. I'll talk now a little bit more about the what. So what did this actually lead to? So I think on the next slide, I share a little more about that. This is really, I'll maybe one more on process. So this is really iterative process. I would say it really started with our stakeholder advisors sharing journey maps about their own experiences with a primary care error or adverse event, and then also some in-depth focus groups and qualitative interviews that were also funded by AHRQ to lead to the actual intervention. Which in this, is really around the core finding we found was that communication was key. And so it was so often that there was some sort of concern or symptom or question mark about something and not clear ways or means to be able to convey those concerns in a timely manner before an actual adverse event occurred. And so that was what really led us to think, okay, really based on what we're seeing so far, there was really something here as far as text messaging as a tool to enhance communication. And so then I think on the next slide, I have a little more. And so then we wanted to trial the fix tool that was from Dr. Bardak. And since that tool was already built, we did a quick and dirty cycle, really thinking about these user-centered design principles. So really, let's try this out. Let's get this going. Let's see what it does. And so that was with adult patients at our public hospital here, the General Hospital. These patients were English speaking, adults who did own a smartphone and had some sort of personal experience with insulin, opioids, or blood thinner medications, because we have found in precedent research that these are medicines that are much more associated with adverse events or safety events in primary care. And so then I think on the next slide. And so here's where this is really what does the tool actually do? So participants, both in this inpatient phase and then in our outpatient adaptation, receive a simple text message that asks, have you experienced any safety issues today? And so so you would either respond a yes or a no, a Y or an N. And you would respond no if you didn't have an issue. If you did have an issue, you can click on the link, and the link leads to a mobile online reporting tool that's HIPAA enabled and would enable patients or family or caregivers to describe what kind of event had happened and also share their narrative. And we provided some categories for them, and then as well as other, and then also an opportunity to provide positive feedback. So an opportunity to say what went well. So that is really that's really the architecture of the tool. It's really designed to be as simple as possible and as brief as possible while still trying to get good information and also really enabling patients to share their own story. Okay, on the next slide. So then we trialed this tool among 10 patients, and each of them got this daily text message for a 2-week study period. You can see that the cohort was fairly diverse, racially, ethnically, and by age. And we found a number of reports in a number of categories. So 16 reports among 10 patients for 2 weeks, which I can tell you right now is definitely more than you might find from our typical built-in safety reporting systems for primary care. However, we found that not one, but 2 of those 10 patients did report, unfortunately, some sort of issue related to chest pain. And that really caught us off guard because we had done extensive counseling and orientation with this tool to not use it for emergencies. The whole point of this is really to be more of a safety monitoring or concern tool rather than a rapid response. And so we even in our orientation with this phase 1, we specifically used chest pain as our example and to use Teach Back, which is highly validated as a tool to help to teach new interventions. And we said to patients, if you had chest pain, what would you do? Still with that, we had 2 incidences of chest pain. So this is part of research, right? So we halted phase 1 and we really went back to our team. We went back to the stakeholder advisors. And so I think that's on the next slide. With our stakeholder advisors, we developed interviews, we asked each of those 10 patients who trialed the tool what they thought. And so the benefits, we found that the tool was really easy to use, it was accessible. There might be some questions about where does that information go. And we also got some good insights into why it might have been used for an emergency. And so I have these quotes here from notes from our usability interviews, but really my takeaway is that, especially in the public health setting, folks have a lot of concerns. It can be really, really hard to get in and to get heard. And so a rapid text message that you get really feels like you're being cared for in a quicker way. And so the timing around this tool, I think, is something we really still need to think about. We, as far as what to do next, working with our input from these interviews and from our advisors, we made dramatic changes to our orientation protocol. We added in multiple stopgaps along the actual portal of the mobile reporting tool to confirm, I confirm this is not an emergency, and to click it to advance. And then we also got another round of display and more interface feedback. Okay, next slide, please. And so then with this revised tool, we then had, because we did really want to hold safety at the core, we said, okay, let's have all our stakeholder advisors trial this out themselves and see what they say. And so that was our next phase of trialing, where we had our even the doctors on the team and the nurses also tried out the tool. So on the next slide, we have those findings, so this is just a little bit of a showing of what changed. So we also changed some wording, and we really made it clear this is about medical safety issues, is a really clear aspect that we wanted to change. Our group worked a lot on wording, really, and a lot on visual cues. Okay, next slide, please. So this is another example where you can see we added a lot of detail about what does emergency actually mean, and we added other stopgaps as well in these updates to really try to make it more safe. And then the next slide. We also changed the categories. We wanted to recognize that the mental model of safety in primary care and ambulatory care is definitely different than inpatient care. And so honing in on the categories you can see for the experts tool that we thought were most relevant and came again from our stakeholder advisors. Okay, on the next slide. So then we had the stakeholders trial it out. And on the next slide, we had 9 folks try it out, again, for a 2-week cycle, again, getting a text message every day, again, just like other participants. And we also had them use the system usability score, which is a well-validated metric to assess how usable a new innovation might be. And we were scoring in the 70s. So the 70s is really considered in the good range. And so we as a group did think that this was an appropriate level for us to proceed. We also wanted to check the digital literacy of our participants. And so that is the eHealth literacy questionnaire. And as you can see, the patients and caregivers did have somewhat lower digital health literacy than the providers and healthcare staff. So that's reflected there. Okay, on the next slide. And so then here, so we also added in, based on that round of the stakeholder feedback, even one more change to this, where we added this link where it says here, and that was a place that people could even see what would be some examples of emergency situations. And we also fixed a little bit of some of the navigation that was glitching or a little bit confusing at the very end of the tool. So it would be clear what to do if you needed to exit versus if you wanted to put in multiple reports. Okay, and then the next slide. So then we felt like we had done a lot to try to improve the tool and improve its safety. And so then we're now in phase 3 with a new cohort of adult outpatients with similar inclusion criteria, adults who have a smartphone, who have experience with insulin or blood thinners, insulin or hypoglycemic medications, blood thinners, and opioid medications. And then on the next slide, so we are deep in the midst of phase 3 testing as we speak. We have a goal of at least 30 participants. We have reached 8. We have 17 reports to date, and I am very pleased to say we have no emergent uses of the tool so far. But since we're actively collecting data, I'm not sharing the nitty-gritty so far. but we're really eager to see what we learn and what happens next, and reviewing that back again with our stakeholder advisory council. And then next slide. So as far as benefits and challenges, really grateful for the work done in partnership with stakeholders. All of this work is at a public health site that serves a diverse low-income population of patients. And so we have high confidence that the tools that we do develop are useful for a population that is often neglected in research. I will say that as far as the challenges, this work, thoughtful work, user-centered work, it does take more time. It's not as easy as someone just working alone in a room. And so it has taken us much longer to arrive at a tool that we think is effective for our patient population. And then, yeah, so I think that's enough for this slide. And then on the next one, I really think we're thinking now about the right fit for this tool in the right setting and the right patient population. And so I think there's a lot to be said for maybe not this tool is for everyone, but for specific high-risk populations in a specifically vulnerable time in primary care. And so that may mean right when you start a brand new high-risk medication. It might mean right when you're discharged from the hospital and that really, acute period of vulnerability right after discharge. So I think those are some really specific applications for this tool that could be coming next. And then, as you can imagine, we really want this tool not to be another add-on. Ideally, it would be integrated into existing systems, be that either the electronic medical record or within our existing incident reporting tools that each hospital has these means for how staff can put in a safety report. So how could patients maybe be engaged to do reports in that same fashion? And then there's also this piece where, seeing how patients really do want that closer contact and that more real-time feedback. Is there a role here for AI? Is there a role here for what my mentor, Mimala Sarkar, calls chatbots for good? Where we could maybe have, for some of these text message concerns, is there a way that we could actually enhance feedback to patients in a way that is safe, but also would it not necessarily incur more burden on our already overburdened primary care teams? So these are all thoughts. I would love to hear what folks think and also the co-panelists might have to say. And so just want to express deep thanks for our entire study team. And that's my contact information if you want to save it, and feel free to reach out. And just big gratitude to our advisors as well as our study staff and my mentors, Dr. Sarkar and Dr. Bardak. Thank you so much.
Thanks very much, Dr. Sharma. So we're going to transition to our next speaker. We can go to the next slide, but maybe first ask folks and remind folks you can submit questions through the chat. So don't be shy. Please submit your questions through the chat, and we'll address those at the end of all the presentations this afternoon. Please join me in welcoming our second presenter, Dr. Adrian Aguilera from the University of California, Berkeley School of Social Welfare and the University of California, San Francisco. Dr. Aguilera will present on his study, Improving Diabetes and Depression Self-Management via Adaptive Mobile Messaging. Take it away, Dr. Aguilera.
Thanks so much for having me. We can go on to the next slide and get started. So first, I'd like to acknowledge the co-principal investigator on this project, Courtney Lyles, who's at Center for Healthcare Policy and Research at UC Davis. Next. Okay, so today I'm going to talk a little bit about our Diamante project, which stands for Diabetes and Mental Health Adaptive Notifications Texting Study. The impetus for this project was an interest in addressing comorbid conditions that influence each other negatively, being diabetes and depression, which are often seen in primary care. And what we know is that interventions for depression and diabetes are often siloed. So you often get treated for one or for the other. And we're motivated by finding core mechanisms for these interventions, for these outcomes, sorry. And one of those is physical activity. So we know that improving physical activity among people with diabetes improves diabetes outcomes, and increasing physical activity for people who are experiencing depression also improves depressive symptoms. We're motivated to use mobile health interventions to try to scale out what we can do, but we know that a lot of work needs to be done to make them more personalized, to better integrate them into care, and to develop them with vulnerable and marginalized populations who often get left out of the development side of the equation. Next. So the primary aim, as I mentioned, is to increase physical activity among patients with diabetes and depression. And we aim to do this by first collecting step counts from individual smartphones, and then using that data to send personalized messages using a reinforcement learning algorithm. So this is a type of machine learning algorithm, which I'll talk about a little bit in more detail in a bit. And the way we plan to personalize is to target individual specific motivators. So there's different things that people need to engage in new health behaviors, and I'll also discuss that in a bit as well. Next. This is an overview of our Diamante app. So this is how we collect data from participant smartphones and their step counts. There's an example of the app, which shows two individuals how much they've walked over time. And then we send them text messages. First, a feedback message related to how much they walked in different ways. We can either say you walked less than your goal. We'll give them the actual number of steps that they did. And that's another thing we vary a little bit as well. And then the follow-up message is a motivating message, trying to get folks to improve their step count that day or the next day going forward. Next. We generated content for the motivating messages using the COMBI behavioral change wheel framework. And so we generated messages related to capability. And so these are messages that we might often think of as educational type messages. So why to engage in physical activity? Why is it important? How is it related to maybe diabetes outcomes, to feeling better? Motivation, we framed as self-efficacy. So getting somebody to move so you can do it kind of messages. And we also did some user-centered design early on in the study for about a year, which was really important in getting to know what was relevant to patients' lives. And here, a lot of folks wanted inspirational type messages. So we really ramped that up when we developed the content. And then the third category is opportunity. And so opportunity is more about thinking, helping folks think about how to engage in the behavior. So putting sneakers next to your bed in the morning, going out to walk with a friend, things like that. Okay, next. And so the reinforcement learning algorithm is a type of machine learning algorithm. So in this case, there are many, but there are three broad types of machine learning algorithms. One would be supervised, which is using existing data that already has been collected and is learning based on that. Unsupervised is kind of learning on the go. And reinforcement learning kind of learns on the go as well, but is very specific to what we call rewards. So technically defined how software agents ought to take actions to maximize the cumulative reward. In our case, the cumulative reward is step count. So the equation is trying to maximize the amount of steps that it's predicting that patients will be taking. Okay, next. So I'll dig down a little bit into this since this is probably not familiar to everybody. Here are some important terms when we're thinking about reinforcement learning algorithms. So the first is action variables. And this is what the algorithm is doing. And so we asked the algorithm to do a few different things. One, to vary the feedback that people got. So the messages related to what they did yesterday. So we might just say, you walked 5,000 steps and just leave it at that. We had a message that would say you walked more or less than your goal, which was set at the beginning of the study, or we would send a message saying, if they didn't meet their goal, kind of you can do better, maybe a little bit more of a push. There was that motivation message, which I mentioned, which we took from the COM-B framework. And then there was the time of day, since that might vary based on when people are more likely to read a message and really act on it. There are contextual variables, and these are related to an individual's characteristics. So let's say their gender, their sex, their age, other factors that are related to individuals, and also their behavior. So what they've done in the past week, in the past month, etc., and what's going on in their surroundings. So for example, we included weather data here. So if it was raining, we could guess that physical activity is likely to be a little bit lower. So the algorithm's taking this into account. The reward is the outcome, as I mentioned, physical activity. And the model that gets put together is how these things are predicted, how we predict the potential reward might be as a function of these action and contextual variables. Next. So just to put it all together, every morning an algorithm is retrained on data of all participants. So we had the action variables, the contextual variables are put together to come up with a reward. So here are some examples of some calculations it might make. So it might choose to send out no message, a benefit message, a self-efficacy motivating message, or an opportunity message. And then it chooses a random message from whatever category it's deciding to try that day. And it's important to note that the actions aren't always the best ones. So it's not going to select a benefit message every single day, even though that one may be predicted to be a little bit higher, because it's going to try out different combinations of messages. The effect of the similar types of messages may wane over time. So these things are taken into account. Next. All right, so now getting into the actual study. So the participants on the setting were low-income patients from a primary care clinic at public hospital, same hospital that Dr. Sharma's patients are at in San Francisco. We worked with English and Spanish speakers with diabetes diagnoses and elevated depression symptoms. There were varying digital literacy levels. So people were not all, super users of apps and text messaging and so on. So we had to do a little bit of training and onboarding. And part of that was related to doing the 1-year design phase to really take into account the digital needs of patients. We ran into a little bit of an issue with this COVID-19 thing, which started right around our recruitment start point as well. So we had to turn to social media to expand our participant pool, where we got about half of the sample. We also sent STEP and PHQ-9 data to primary care physicians via electronic health record messages. So our integration could be better, which I will talk a little bit about at the end, but there was some integration. And I think importantly, patients felt these messages as being part of their clinical care, generally speaking. Next. Here you can see the trial design, where participants were in 3 different arms. The adaptive arm is where they were receiving those reinforcement learning messages and a weekly message asking them about their mood rating. The random arm was folks just getting the same messages as the adaptive arm, but randomly. So there was no algorithm that was turned on. Messages were just sent at random. And then the control group just got the app and was asked to track their steps and then received a weekly mood rating message. Next. So here are the numbers of folks who participated in the intervention. I think a few things to note here are The average age was around high 40s to low 50s. A little bit higher female participation, but it's actually not too bad when we look at other research studies that tend to have a higher female participation. Significant Spanish language speakers, and a good mix from racial and ethnic standpoint. Next. Again, given our focus on diverse, underserved populations, education levels also range quite a bit, with a fair number with only a high school education or even less, and then also a range in employment status. Next. So before the study, folks were averaging somewhere between 3,000 to 4,000 steps a day, which is fairly low. So it is a population that could stand to use some help improving step counts over time. Okay, next. So now to the final outcome. So we did find that the adaptive arm indeed had higher step counts over the period of the study. So the study lasted 6 months, and their steps increased over time, whereas for the random and control arm, they were relatively flat or even slightly declining. So that's a promising result, showing us that personalizing these messages can provide some help in increasing step counts for folks with diabetes and depression symptoms. Next. So some of the implications are broadly that text messaging in particular, people talk about it as a workhorse in digital health. We saw in the previous study by Dr. Sharma was also using text messaging. It's not the fanciest, but it provides a sense of connection and ease of connecting with people that relies less on using an app, which requires much more engagement. Personalized and adaptive interventions may be particularly effective at increasing activity. And we know that this is where things are going. So we started this project back in 2017, I believe. So I'd like to think we're a little bit ahead of our time, but the move is more towards personalization. Now that we're moving towards large language models, for example, we're continually moving in this direction. And I think it is a direction, if applied properly, as Dr. Sharma mentioned, for good, can have a positive impact. And our hope is that the ideal is that it reduces existing disparities. An area to continue to work on is to better integrate these tools into care and more seamlessly into the electronic health record for improved implementation. There is a sense that people are more likely to engage in these digital tools when they feel that it's part of their care, that it's coming from their doctor or their doctor's office and their care team, versus if it's just a standalone program that's separate. Okay. I believe next, I think that's it. Never mind. Yep. Thank you very much.
Thanks, Dr. Aguilera. So a quick reminder for folks on the line and watching, please do think of questions and submit those to the chat. We'd be happy to take those after all the presentations are done. Let me now introduce our third presentation for today. We have two principal investigators, Dr. Ryan Collar from the University of Wisconsin-Madison School of Medicine and Public Health, and Dr. Nicole Werner from the Indiana University School of Public Health, Bloomington. And they will present on their study, Improving Medication Safety for Medically Complex Children with mHealth Across Caregiving Networks. Welcome, Dr. Collar and Dr. Werner.
Thanks so much, and a huge congratulations to the co-presenters for the really exciting work, and we're thrilled to be able to share ours as well. I'll get us started off on the next slide with a little bit of background. There could be a misconception that children don't necessarily use a lot of medications in general, but the reality is, according to the data, that more than half of children in the United States take at least one medication per week. And as many folks can imagine, a lot of those medications are given in formulations that can be difficult to give accurately, such as liquid medications, or the child kind of struggling to take what's given to them. And alongside that, we see that the vast majority of medication errors are happening really in home and community environments. And this statistic at the bottom is quite staggering, that every 8 minutes a child experiences a medication error during routine care at home. And on the next slide, we're zooming in on a population that Dr. Werner and I have been particularly interested in working with on this topic, and that's children with medical complexity, that you'll see abbreviated as CMC. And if you haven't heard of that population before, the way that they're typically conceptualized is in the figure at the top right, where children with medical complexity live at the intersection of four related concepts. They've got chronic conditions, severe functional limitations, high service needs, and healthcare use. An image of a child's daily medication regimen who's got medical complexity is photographed at the bottom right, where you can see that there's multiple different formulations, including injections, topical medicines, liquid medicines, and tablets. And this population in general takes medications that are particularly high risk because they're frequently drug-drug interactions, and the space between a dose that's effective and a dose that's toxic can be kind of narrow. So this group is particularly vulnerable to medication safety challenges, and you see that in some of the healthcare use data that's at the bottom of the slide, where children with medical complexity are 5 times higher odds of having a ED visit due to an adverse drug event than other children, and many of those lead to hospitalizations. On the next slide, what I wanted to really illustrate here is some work by a collaborator of ours, Dr. Feinstein, and his team, that has put data behind the complexity of medication administration that I just was referencing. So the figure on the left is a way of looking at a medication regimen for a child with medical complexity using an index called the Medication Regimen Complexity Index. And what that does is it's a composite that really brings together the number of different dosage forms, frequencies, and special instructions that span the child's daily medications that they receive. And the top part of this figure shows that children, whether you look at low index scores or high index scores, they're ranging between 4 and 8 different forms, 4 and 8 different frequencies, and 4 and 8 different special instructions across their regimen. And at the bottom, the really striking point of these data are that children, even with the least complex regimens who have medical complexity, are being administered 20 different doses throughout the day. And that number jumps up to 50 different doses of medications given in the home when they've got the more complex regimens. The figure on the right shows a different and very understandable consequence of this complexity. So the histogram bars in white are parent self-reported mastery of different medication-related tasks. So indication, knowing the indication, the dosage, and the measurement of the child's medicines. And the black bars are the demonstrated mastery when observed. So you can see a huge discrepancy between perception and demonstration of medication mastery, which is, again, understandable given the complexity. On the next slide, there's an element that hasn't really had a ton of attention yet in quantitative research, but we all, I think, qualitatively understand that there's another unique attribute of children with medical complexity that is at play here. So Lily, in this figure, which is called a care map, commonly used in understanding the world of a child with medical complexity, Lily's at the middle, and she's surrounded by her family. And each of the hub and spoke surrounding her areas in different colors represent different domains of her life, different aspects that really are critical to her thriving. There's a lot. And each of those little bubbles can represent a person or a service. And many of those might be places where Lily needs to have medication given to her or care tasks given to her. So you can imagine there's this really critical need for those different people and settings to be coordinated and communicating with one another in order to do this well and give her safe care. So on the next slide, a really nice recent publication, I think, distills down a lot of where our work has led us. These are primary drivers through a key driver diagram to really focus on safe medication administration in the home for children with medical complexity. And the authors highlight medication management, care coordination, patient and family engagement, which is exactly what our work is trying to achieve. So on the next slide, I'm going to just highlight two gaps that lead us into our technology solution. So the first is really we lack tools that can address those challenges for the sheer complexity of medication administration for CMC caregivers. And the second is that no tools really exist well that are designed for CMC and their families to support coordination across the network of folks who are involved. And on the next slide, Dr. Werner will take over.
Dr. Collar. So our goal was to address those gaps that Dr. Collar just highlighted through a family-facing mobile health information technology that could manage medications and manage care and coordinate and communicate that care among the caregiving network, all those caregivers that are involved in care. And we wanted this technology to be designed by the families and other stakeholders that would be using them. So through some initial funding through the Maternal and Child Health Bureau Mobile Health Challenge, we did engage with families as the designers to create prototypes of an initial solution focused on tube feeding to start. So you can see here on the screen some of the photos of us working with those families across co-design sessions, starting kind of with sketching and creating these paper low fidelity prototypes and moving all the way toward an actual usable prototype, excuse me. So I'd like now for you to just hear the words of one of the parents that participated in a co-designer about how they think this digital solution they designed is going to influence the safety and quality of their child's care.
Because it's a one-stop, one area where they can have all this information and have that inputted and make life simpler and hopefully cut off on human errors and in between caregivers and spouses even. And
thanks. You can go to the next slide. So building on that foundational work, so we built on that foundational co-design and were able to develop the app and test that initial prototype with families. And in that feasibility test, families reported that Tubes at Home, which was the original version, was usable and useful and also feasible for use over a period of time in the home. Next slide. So we were able now to build on that foundation of work for the current proposal that we're talking about today, where we're seeking to adapt that initial Tubes at Home prototype using, again, co-design with families and other key stakeholders focused on supporting and improving medication safety for the child among the caregiving network. And we're calling this Meds at Home. And after we developed the app, we're testing the effectiveness of Meds at Home to improve medication administration accuracy in a randomized trial with families in the home. You can go to the next slide. So in our first aim, where we're adapting the design of Tubes at Home to create Meds at Home, we convened 3 groups of designers. So primary caregivers, which were parents of children with medical complexity, secondary caregivers, such as school nurses, home health nurses, and clinicians who care for children with medical complexity. So we had nurses, complex care pediatrician, pediatric clinical pharmacists, and someone from a home health representative. And we brought them together for a series of co-design sessions. So you can go to the next slide. And here is just a kind of table schematic of the co-design sessions that we did with these 3 different groups of stakeholders. And so we held 4 design sessions with the parents and 2 design sessions each with the secondary caregivers and the clinicians, ending evaluation, individual evaluation with the family so that they had kind of the final input on the design. And we integrated the secondary caregivers and clinicians in between the co-design sessions of the parents so that we could make sure we were getting different stakeholder design, but that the parents were kind of driving, as the main users, were driving the major design process. We used weekly meetings with our team to have consensus discussion and plan for the next session, and work with our user experience designer and software developers so that we could make prototype changes in real time in the sessions, integrate all the feedback or all the designs that the co-designers created in session, and have those ready for the next session. So it was really a creation and development happening iteratively and in real time. You can go to the next slide. In our sessions, what we focused on is a 5-stage process that we use in our research for co-design, where we start with identifying the problem and we generate solutions, converge on those solutions, prototype, and evaluate. And so the 3 key challenges that our stakeholders and parents, secondary caregivers, and clinicians identified were giving the right medications at the right time, communicating about medications to the rest of the care network, right? So when was a medication given? And parents often talked about this leading to double dosing or missing a dose, and accommodating complex medical needs. So how to integrate all the other complex care needs, symptoms into medication management and the communication of that medication management to the rest of the care network. You can go to the next slide. So what we did is we took those, throughout those sessions, we took those initial challenges, and the co-designers generated specific design requirements to address each of those challenges, and converged upon and prototyped this design. So you can go ahead and play the video.
This app is designed to help manage complicated caregiving tasks and medications. The home screen shows important alerts, care routines for the day, and medication refill reminders. The basic functions can be found in the task menu at the top left of the screen. Tapping the icon in the top left of the screen opens a menu with several options. The Medications and Routines tabs allows primary account holders to add, edit, or delete medications and routines. The Calendar tab shows upcoming and previously completed routines week by week. The Notifications tab displays notifications about upcoming and past due routines, as well as refill notifications. The My Profile and Child Profile tabs display important account information and can be edited at any time. Check out the other videos to learn more.
Thank you. You can go to the next slide. So now that the designers, the co-design teams have created this prototype, we're testing the prototype that they created with families in a randomized clinical trial. And our goal is to evaluate the effectiveness of the Meds at Home app they created on medication administration accuracy, with the hypothesis that medication administration accuracy is going to be improved with the use of Meds at Home, both in the effect on primary caregiver medication administration accuracy, and then also the effect on secondary caregiver medication administration accuracy. I'll turn it back over to Dr. Collar.
Great. On the next slide. So we are, we'll be excited to report back results when they are done. We're thrilled to have the opportunity to conduct this efficacy study, but we also recognize that as a single site study, there's limits to what we can learn, particularly around implementation. And so we're hoping for a subsequent step to be able to look at both effectiveness and implementation together. So that's one of our immediate next goals. And then beyond that, or perhaps in sort of simultaneous with that, there's a lot of things that can be easily built into this platform that we've got our eyes on. So action planning, for example, if a child has an acute health crisis, a lot of times there's need to respond quickly and accurately with medications and other caregiving tasks. So we're looking forward to the opportunity to build some of that functionality into the technology platform. And then as we've been hearing from the other speakers and in other research, the opportunity to use this information that's being collected by families and other caregivers throughout the day gives us the opportunity to use that information in order to monitor health as well as make predictions about health outcomes that might be impending. So we're looking forward to the opportunity to build out more of that as well. And then as it relates to the connection to the EHR, I think that's a nice segue into our final slide, which is about integration into primary care. Interestingly, when we began design sessions, the question about integration into the EHR came up, and it really wasn't prioritized by families as something that we should focus on right away, because they really wanted tools that they could use themselves within their own environment. So that hasn't been the focus to date. But what we think this work really allows us to do within the context of integration into primary care is shed light on what's really others have referenced as the invisible system of care, particularly for individuals who have multiple complex and chronic conditions. It's a very sophisticated system of care that families and caregivers have to develop and manage. And tools like this allow us to make that work less invisible, gives us the opportunity to study what's happening and implement supports to that, and really create more of a seamless line between healthcare settings and settings at home and community. We think EHR integration, when we do go down that road with this technology, is going to open up new opportunities for communication between these caregiving teams and clinical teams. And we think there's opportunities to promote a lot of what happens in primary care using the technology. So, for example, in pediatrics, we have Bright Futures as a anticipatory guidance framework, and the opportunity to deliver recommendations, ask questions, connect to resources asynchronously from clinic visits in a more automated fashion using technology like this would be one potential way we could see leveraging this to achieve better integration to primary care. And I already mentioned remote monitoring, and at some point we'd love to apply AI and machine learning to identify risk and intervention points. The key unknowns we've listed there are things that we'd be happy to elaborate on more in the Q&A as well. Those are open questions that we're still wrestling with ourselves. And on the next slide, I will just say, Nicole and I wanted to thank our co-investigators listed there, our research teams doing the heavy lifting, and our community partner, Barbara Katz, has been really a lifelong advocate and policy expert, and partner with us as an individual and through her work with Family Voices of Wisconsin. Thank our family and community co-designers and our software developer, Noble Applications, as well as AHRQ for support for this work. And with that, we will say thank you and move to the Q&A.
Yeah, thanks very much, Drs. Collar and Werner. So now we get to the fun part around the Q&A. So again, for those in the audience, if you have a question for our presenters, please do submit those in the chat. And I can start us off as the moderator. I guess I will take the moderator's prerogative and build on some of the things that Dr. Collar mentioned in his last slide, and that has to do with integration into primary care systems. So maybe we'll start with Dr. Sharma. You alluded to it also, so this is your chance to expand a bit on your thinking of how your technology might integrate into primary care systems, whether it be EHRs or other technologies, and in particular, if you can comment on what do you think the workflow integration or implications might be if it were integrated into the EHR, that would be great. So we can start with Dr. Sharma. Thanks.
Thanks for that good and tough question. I think the difference, I think, with our challenge is that even safety incident reporting is not well integrated with most EHRs. And so I think that there's a divide in a lot of the patient safety reporting tools that we have, even from the clinician side, that don't talk to like Epic or other electronic medical records. So I think that that's like an additional challenge that we are being faced with. The piece I feel we really need to solve would also involve integrating with pharmacy. So I think a lot of what, and I'd be curious to hear what the what Dr. Call and Dr. Warner think as well, because I think that it's actually the triad interface between the clinician, the prescriber, the pharmacy, and the caregiver that doesn't talk to each other. So I think independent of our text messaging tool, I think there's a lot that's broken already that we need to fix. But I think what would be a easy and direct idea for this tool, the way that we have been handling messages is in our small team. I'm a clinician. I've been reviewing the events and I've been integrating it myself into the electronic medical record through making a research encounter or a telephone encounter. And so I think if there was a way that the tool itself could just trigger a MyChart message. We use Epic here. I have no affinity specifically to Epic at all, but just as an example, that if those could be safety reports that could then just go in as a patient message, that's one option, because that would trigger a nurse triage. I think the elephant in the room is that at some point patients will want text messaging with their EMR. I don't think most primary care docs want that. I don't think most clinical teams necessarily want that, but I don't see how that doesn't happen in the future. So I think that if that was a mode, this would be a way sort of to have a safety flag on safety text message events that I think could be feasible. So that's all I got. Thanks.
All right, that's a great answer, and it's a good reminder. I think Dr. Collar mentioned this also. Not all applications or technologies at the outset should be thought of as being integrated into EHR. There's some pros and cons to every application, every platform. So, Dr. Aguilera, do you mind expanding a little bit about what you think your platform might have in terms of potential for integration or not?
Yeah, I think the challenge with any of these intervention, these digital interventions being integrated into care are making sure that the information that gets sent to providers is important, actionable information. I think, the worst thing we could do is just send a bunch of raw data. Like nobody wants to do that. And I think first we need to show that these things work, and then the part of a kind of an implementation outcome to look at how we can then deliver this information. So for example, we delivered it via emails, messages in the record to providers, showing a basic graph of step counts over time. There are more sophisticated ways to do that, but a real challenge is you have to build these tools into the EHR, which are often hard to access because we can't go in and just build things. I think the key is getting things in ways that are digestible. I also think we need to do work talking to primary care providers, asking them what do they want to know, what do they want to see. So I would think physical activity is something that providers would like to see, but they'd probably want to see it in a digestible way. So maybe just generally, what has been the trend of physical activity for the past few months, right? And then have a conversation about that. And I think we could apply this to some other things. We already ask for things such as PHQ-9 ratings and other things. So again, we really need a lot of work in terms of how is this information delivered.
Thanks very much. And Dr. Collar and Dr. Warner, any comments around more comments around technology integration or workflow integration?
I can start. I think that one of the challenges that we didn't allude to, some of the practical things, we're deliberately trying to get a tool into the hands of people that are going to be sharing it with others in their world. And so I think the barriers around like who has access to what kind of information is something that's a unique challenge that we haven't entirely addressed when it comes to if you've got an EHR that's potentially talking to the app, if they're talking together. So that's something that's been interesting. And then the other thing is many of our patients have the potential at least to be seeing providers at multiple institutions. And so that creates a lot of additional challenges of integration of a single technology potentially across multiple institutions. So those are just two of the things that cross my mind. And then I guess the other that's pediatric specific is around privacy, as the caregivers are really the owners of the information, and decision making, but that obviously switches as the child becomes a teenager and an adult. And in our population, we have a lot of folks who also might have guardianship, and there's just a lot of layers of complexity that need to get, I think, addressed, particularly when it relates to integrating with a health system's structures. So those are barriers we foresee, challenges we foresee, lots of opportunities to work on them. Nicole, chime in on anything else I forgot.
Yeah, just a quick chime in about, not that you forgot everything, I thought you covered it, and just kind of speaking to all three of the great comments that like, we really need to think about not just what do the clinicians or primary care clinicians want or need, or what's useful to them, but also like how are we going to fit it into their system? So not just in the EHR itself, but in, where in the workflow would this information be provided? Where in the workflow would they be using it and communicating it to the patient or family? And really thinking more like stepped out from the technology, like what's happening in the room, what's happening in the clinic, and how are we going to integrate that more from like a systems engineering perspective?
Yeah, those are great points. And I think we'll build on this a little bit. And Dr. Aguilera, you touched on this already a little around, what do you think, clinicians might think about technologies like this, if we are able to successfully get them into the EHR, and if they're appropriate for that. And as you think about those workflow questions that Dr. Warner brought up, any other thoughts around, for folks listening, what kinds of things they should think about if they're thinking about developing or integrating technologies like this from a primary care clinician standpoint? Did you guys hear that? I think that was for Dr. Aguilera.
Sorry. I think really the key is what value is this adding, right? And I think providers have to see value in these tools in order to use them. They have to see that they're creating a real impact that they're interested in seeing. I think in the example of our project, I think physical activity is such a core mechanism across a variety of health outcomes, right? Providers often try to encourage patients to be more physically active. So we took that on as a pretty basic health behavior because we think it applies quite broadly. Even though we focus on diabetes and depression, we think that it can have broader implications to most health conditions. And so I think starting with something that folks are already doing and trying to find a way to do it a little bit better with less effort, so that we know that the conversation around you should be more physically active is not going to do very much once patients leave the room. So we need to find other ways that are kind of targeted and focused on something that is core. I think one of the things we often get in trouble with is developing more complicated apps and digital health tools that are just doing so much, that are asking patients to do a lot. And it can be beneficial if they meet that really high bar. Our approach is to kind of lower the bar a little bit, and let's start with, key behaviors, maybe individually, and maybe once that is mastered, we can kind of move up. And I think that, sending back that data to providers is a lot easier than engaging in a really comprehensive app, maybe that's looking at even, how managing a lot of other things around diet. Diet's a whole nother, kind of worms, which is important, but there are a lot of elements within that. And, even stress management and other things. So I think kind of going at it from individual behavior, at least, maybe this would also allow targeting to patients who specifically need that as a target intervention, and maybe need to emphasize some of the other things a little bit. So I think it comes down again to value for patients and for providers, and then feedback of information in a really clear and useful way.
Thank you. And Dr. Sharma, you mentioned this earlier around value for you. Your application or technology is a little bit different qualitatively around event reporting. So you mentioned, using it in your own practice. If you were to get reports like this, how do you do that? And there are things that you would teach or talk to other clinicians about using that kind of data?
Yeah, I mean, I think as a primary care doc myself, I think it does keep me up at night thinking about how complex some of these medication regimens and diagnostic follow-up steps are. Even, I mean, the amount, and as I'm also a caregiver myself, and so for a family member, and it's speaking to that invisible burden, it's quite overwhelming. So I think that that's the in as far as how PCPs and clinicians can help to utilize this data, is really naming that this is really what we know is really the tip of the iceberg, and that there's so much that families are facing at home, in the community, between visits. So I think it's my hope is that the in would be really to try to help assuage some of those fears about what we don't know is actually happening, and have the sense that patients do have some safe avenues for how to convey when something may not be going as expected.
That's great. So waiting for some questions coming through the chat. I think we have a few more minutes. I'll ask another one kind of along these lines, and you've kind of touched on it already. If you were going to scale or spread your innovations to not just within your healthcare systems or immediate environments, but to others, or give advice to folks who might think about similar applications, what would be the one or two things that you would ask them to think about first? Kind of a big picture kind of question, but a good one from a funding agency perspective. Let's start with Dr. Collar and Dr. Warner, if you don't mind.
It's the race to see who's going to go first between us.
Go in alphabetical order.
I think that I'm first and foremost a clinician and physician researcher. So I've learned a lot by partnering with Dr. Werner about user-centered design. And I think if you're talking about trying to have an intervention that at the outset is going to be potentially scalable and implementable and things like that, I think you really have to begin with those approaches and those methods. So I've really appreciated having our work be able to take advantage of co-design with users from the get-go. And I feel a lot of optimism that as our work does scale, that it's going to have a good potential for wide uptake. We've integrated a lot of customization into our tool so that families can use it to get down into the granularity and minutia, but at the same time, a user could be pretty high level with our technology, and it works for both of those instances and everything in between. Same with who gets shared the technology. And so I think that those are the kinds of things that will promote use and usability, and then a lot of prototyping that we've done along the way and studying the usability through qualitative and quantitative methods to then tweak and adjust and try to meet needs. I think we are seeing a lot of our work starting with a foundation and adding to it kind of in a little bit modularly, so that we can continue to try to design a solution that is being asked for, frankly. Before we even started this work, we surveyed our clinical population to understand, would something like this even be useful or of interest? And we had, a really resounding yes. So that was motivating. But I think a lot of that is kind of one of the ways that we've thought about the potential for scale. I think there's a wide array of other questions around sustainability and infrastructure and things like that we could certainly touch on as well. But I think that's the first stuff that crossed my mind.
Thank you. Anyone else with comments around or advice for scaling potential these interventions, or practical advice for folks who want to take your approach in other places?
I would say just a couple of things that we've learned in our work is, in addition to, I think, the user-centered design comment, is finding obviously problems with need that are relevant. But also, I think one thing we often don't think about, and it's counterintuitive in some ways, is working with populations who maybe have more of a challenge engaging in these digital tools. And although we often think about, using digital tools with people who are already comfortable with them, I think we actually have a lot more to gain when we develop tools with and for communities that don't get targeted with these types of innovative interventions typically. So for example, we work a lot with Spanish speakers. When you develop an intervention in Spanish, there's a relatively high uptake compared to other populations because they don't have as many tools at their disposal generally. And I think we often don't take that into account because what ends up happening often is the same people are being the targets of a variety of tools, and they have more access to tools, and then the marginal improvement is relatively small. And so I think that if we target populations that are more underserved, we can get actually a bigger bang for our buck.
Thanks very much, Dr. Aguilera. So I think we are at time. I'll just take the opportunity to thank you all for presenting amazing research, and I thank the audience for participating. I'll turn it over to Kayla.
That concludes the webinar. Thanks everyone for joining.